So let's move on now to rarer yet actionable mutations in non-small cell lung cancer. And we've learned a tremendous amount recently about NTRK fusions in non-small cell lung cancer and RET fusions. Alex, you've really led the way on this with the recent publication, your first author on in New England Journal of Medicine, and then a nice oral presentation at this ASCO on two of these drugs. So you want to start out with the NTRK fusions, talk about the relevance potentially in all cancers and specifically in lung cancer, and then talk about the activity of the drug?
Yeah, absolutely. And I think this really highlights a dilemma that we're going to start to face as we kind of use up the more common drivers. And we now have to deal with very actionable alterations that may be found in less than 1%. And actually, recent data for non-small cell lung cancer shows that these TRK fusions may be in about 0.25% of patients. However, it's fortunate that these NTRK fusions that, put very simply, behave similar to ALK and ROS and RET1 are found across many different cancers. In fact, there are some cancers where the frequency is greater than 90%, and so the fusion is almost pathognomonic. But this data set was a data set of a variety of different cancers, 17 unique types. All of them harbored an NTRK fusion. This included patients with non-small cell lung cancers. And the overall response rate exceeded 70%, both for the investigator and the confirmatory radiologic assessments across all tumor types. So this is very different from what we're seeing from before, where we've tested drugs within a particular histology. Here we're seeing tumor-agnostic responses to therapy. It means as long as you have the appropriate target, it doesn't seem to matter what the cancer looks like under the microscope. And actually, the drug is up for potential approval maybe this year.
So larotrectinib is the drug and seems to have just a real practice-changing implications. Eliciting these types of response across multiple tumor types, it really kind of, for me, reinforces this whole concept of really, we're really looking at the genotype, tissue agnostic, looking at shared genotypes and getting responses out of drugs that target these genotypes. Toxicity from the larotrectinib in terms of, well-tolerated drug and
Fortunately, it looks like a very well-tolerated drug, and that's not just based on our experience with patients that we've treated, but if you look at the adverse event profile, there were very few treatment-related adverse events. Rarely you might see things with chronic dosing like an increase in weight, some paresthesias, or even some positional dizziness that's related to proprioception. That's because the TRK family plays a role in the development of the nervous system. So we're seeing some unique side effects, but by and large, these drugs, larotrectinib and another TRK inhibitor, entrectinib, that's also in development, are fairly well tolerated.
So you covered how do you test for NTRK?
Yeah, so I was going to ask, we can talk about this in the testing section, but just briefly, how was NTRK fusions interrogated, identified in the study?
So an interesting feature of the study was that this wasn't central confirmation of the fusions. We allowed investigators to use a variety of different local molecular tests. And I think the best way to look for this would be to use a good NGS assay that detects not only NTRK with good enough fidelity, but also other alterations, and we can get to that later. Yeah. IHC does play a role. There are many cases actually that highly express TRK, and so it's reasonable in regions where you may not have enough resources for NGS to maybe start by screening with IHC, especially for those histologies with a high pretest probability. But at the end of the day, I would feel most comfortable confirming that with an NGS test prior to treating somebody.
Really incredible data and very welcome to see, yet in remembering that these are rare fusions, but ones we need to test for given the data we have with these drugs that are so well tolerated.
Yeah.
And along that theme, we have a RET drug.
Yeah.
And with LOXO-292. I hope I got that license plate therapy right.
Yes.
And your presentation blew up my Twitter ASCO this year. So I want to get your insight onto that. And that was just presented yesterday, I believe, or 2 days ago, looking at the role of LOXO-292 in RET rearranged solid tumors. Yeah.
So just to summarize, RET rearrangements are, in terms of frequency, about comparable to ROS1 rearrangements. And we've had older drugs like cabozantinib, vandetanib, that can achieve response rates maybe in the order of about 30%. But the problem is they were very dirty drugs, and so they had a lot of side effects because of the inhibition of other non-RET targets. Fortunately, now we have RET selective or more specific inhibitors that are cleaner and zoom in on targeting RET, and you don't get a lot of those off-target side effects. This data that I presented on LOXO-292, one of these selective RET inhibitors, shows that the response rate in RET fusion-positive cancers that included lung, papillary, and pancreatic adenocarcinomas exceeded 70% confirmed response rate. So
And these were
hopefully,
pre-treated patients for the most part?
yes,
Or, okay.
heavily
Yeah.
chemotherapy, immunotherapy, and many had one or more multi-kinase inhibitors in the past. 2/3 of patients were pre-treated with a prior RET inhibitor. So I think it's fantastic data, and we've been waiting for this for a very long time since we discovered RET fusions in lung cancer in 2011. And hopefully now we have a drug that's comparable comparable to what we're seeing with ALK and ROS1.
Alex, when you pull out the lung cancer patients, how many were there and what was the response rate for lung cancer?
Yeah,
for the
so it was
non-small cell
still
cancer
more than
cohort?
70%, and there were about 30 non-small cell lung cancers with RET fusions.
So how do I get this now for our patients with lung cancer?
Send them to me.
So just for balance, there is another drug called Blue 667 that's currently in the clinic that's also RET selective, and both of these drugs are currently in phase 1 testing with phase 2 or phase 1 expansion cohort. So these are available at multiple centers for patients.
Do we think these drugs, both larotrectinib and LOXO-292, I mean, similar to the other genotypes, do we want to use these drugs first? Is this where the approval is going to come in?
In my mind, when you have response rates that exceed 60, 70%, I think they should be used in the treatment-naive setting.
Yeah.
Again, use your best drug up front.
Front.
It's the theme
Right.
of our conversation today.
Yeah. So well, I look forward to seeing more of this data and an update and getting a better understanding. The drug is well tolerated, eliciting response
Very well
rates.
tolerated.
Yeah, I mean, this is seeing how many of these drugs elicit response rates north of 70 or improve survival, but also are extremely well tolerated. I think we've really have done a good job of refinement of the off-target effects and really making these a patient-centric experience. I mean, these patients are able to take very well tolerated drugs.